Just one.
Yeah.
Yeah. Just
Good afternoon, everybody. This is Dr.
Bharat bhai, 2
Bhatt
minutes.
on
Bharat bhai,
behalf
2
of.
minutes. Done. You're on live now.
Good afternoon, everybody. This is Dr. Bharat Bhatt on behalf of GPA. I welcome you all to this webinar. Today we have got three eminent speakers, and today's coordinator is our senior active GPA member from Vasai, that is Dr. Suryakant Pandit. May I now hand over to Dr. Suryakant Pandit to proceed.
Good afternoon, everybody. Thank you, President, sir. We are in the midst of still a COVID-19. It looks it's out, but still we are very much into it. And most of the family physicians are going to have a brunt of COVID patients and post-COVID patients. To begin with, we have with us Sitesh Ray, who is going to speak on COVID-19 unique features and unit presentation. He is super specialist in immunology, allergy, and asthma. He's been trained in USA. He is founder director of Dr. Roy Health Solution Multi-Speciality Clinic, Bandra. He is ex-professor of pediatrics and medicine at University of MS Medical Center from Jackson, USA. Sir, please begin with your topics. Dr. Satish Ray, please start, sir. Thank you.
Thank you very much, Dr. Pandit, for the kind invite. I also thank the General Practitioners Association of Mumbai and the Hetero team for inviting me to do this program today. It is my great pleasure to be with all of you and to go over this very key and important topic that affects all of us in our day-to-day lives on a personal level as well as on a practice level. So what I will be covering in the first part of this session will be the usual and unusual presentations of COVID-19 and also looking at some of the key features regarding its transmission and prevention of transmission, which will be hopefully helpful to each one of us in our daily lives. We all know that COVID-19 or coronavirus is an old foe. We've had them around since the 60s. They've been recognized and known to cause respiratory viral symptoms, common cold, fever, along with systemic symptoms. And SARS-CoV that came out in 2002-3 was a major episode but ended quite quickly. And MERS, which came out in 2011-12, also was a very severe infection with over a 30% mortality, but again ended quite quickly. Then we had from the same beta coronavirus family, the SARS-CoV-2 virus, which is 25 times larger than SARS virus, but happens to be more infectious, has pre and asymptomatic transmission, is quite stable outside the human body at a variety of temperatures and humidity that I will mention and discuss. We all know that the entry is through the angiotensin converting enzyme, which receptors which are present in pretty much every single organ in our body. And the more we learn about this disease, we even now know that there are receptors called neurolipin, which are in our nervous system, which also give direct access to this virus to our brain, our spinal cord, and other parts of the body. So this is really a very widespread virus with a variety of different areas that it can affect. The first recorded case, if you actually delve into this, was in Wuhan in November 2019, following which there were 60 more cases by December 20th before the WHO office in China got the report on December 31st, and the first case outside China that's officially reported as Jan 13th. Human-to-human transmission was confirmed by Jan 21st, and we had cases in India by Jan 30th. That was in Kerala with someone coming back from the Middle East carrying it to us. When we look at the Johns Hopkins COVID data dashboard, we realize that India is only second to the US, which is really ravaged by cases, and they are up to 292,000 cases per day as per yesterday. And India at about 9.8 million is already quite high. But when you look at the recovery rate for India, I think that's a blessing in some ways. And when you look at the global deaths, we are definitely below the two other leading countries, the US and the Brazil, which are also quite affected by this disease. where the mortality rate in other parts of the world is around 4 or 5%, we are at about 1.7 to 2%. And that, I think, has been an advantage for us. The routes of transmission, we very well know this, that aerosols are the primary method, but airborne transmission and obviously contact or droplet transmission through fomites are very, very important. And as we know, these viruses are also present in urine, stools, in other bodily fluids. And the entry, however, primarily is through the eye, nose, and mouth, as we well know. So coughing, sneezing, talking loudly, shouting, singing, even speaking indoors, and then transmission from fomite surfaces, door handles, laptop, phone, common kiosks. There are so many different ways to get this virus. Feto-maternal or transplacental transmission has not really been confirmed. And this is where we look at the viability of this virus. This was an eye-opener for me, a very well-done study from Australia, which looked at 20 degrees, 30 degrees, and 40 degrees for amount of time that the virus stays viable outside the human body. And if you look at 20 degrees Celsius on metal, glass, and plastic, which are solid impermeable surfaces, it's up to 28 days that you can get culture positivity for a swab taken from that surface after exposure to the virus. On paper and cloth at cold temperatures, 14 days it can survive. At 30 degrees, we see that it's 14 days for the hard surfaces, and for the soft surfaces, 7 days. And 40 degrees Celsius, where India falls between the two, it's about 1 to 2 days for these different surfaces. And wherever there is light, sunlight, we know that 90% of the infectivity is lost within 8 to 19 minutes, which is so important for us to know, because we do have abundance of sunlight, except Mumbai has been fairly foggy and also raining in the last 2 days, which means that we can expect a rise in viral infections after weather like this. And so this is happening at a very good time for all my general practitioner brethren, because we can expect an increase, because with the modes of transmission of coughing, sneezing, talking, we do realize that the viral culture is primarily in the 9 days after symptom onset, especially in mild disease, but those who have severe disease can have viral culture still coming positive up to 14 or 20 days after the infection symptoms begin. And so in this process, we have to really take care and guide our patients. When we look at the timing of the SARS-CoV-2 transmission based on symptoms, we realize that just before or within 5 days of symptom onset is where the maximum intake is seen of these patients when they were exposed. And when we look at the asymptomatic transmission, we realize that anywhere between 6% to 41% of the people can be positive, can be transmitting this disease. The range is quite wide for this, but we do know that asymptomatic transmission very clearly occurs. And the other thing that occurs is pre-symptomatic transmission, and this was given onset on given a day following the exposure, and the estimation was 23% of transmissions occurred prior to symptom onset of the active case, and 46% if you do something called accelerated case isolation. So clearly we are dealing with a very smart foe, if we may put it that way. We also know, and this is a very important point for us to share with ourselves, our families, and with people, is that the odds of transmission are 18 or almost 19 times higher in an enclosed indoor environment than in an open air environment. And I know a lot of people who have not even ventured out of their houses. I just had a lady this morning who came out of her house the first time today to come and see me after she had gone, after the lockdown had been declared. So we do have to realize that the majority of transmissions are occurring only in closed environments and not in outdoors. And so with the right kind of mask, social distancing, and all precautions, a person can exercise, go for their walks, jogs, and do different things in a careful manner. When we look at the primary symptoms, which may appear 2 to 14 days after exposure of the virus, as I said, the mean duration is about 5 days, right from headache, cough, sore throat, shortness of breath, difficulty breathing, nasal congestion, runny nose, loss of taste or smell, fatigue, body ache, fever, chills, nausea, vomiting, diarrhea. These have always been known, but there's a lot more that goes on in this disease. And we do realize that GI manifestations like even stomach ulcers, hepatobiliary obstructive lesions, ocular lesions like conjunctivitis, cardiovascular problems like heart attacks, myocardial infarctions, myocarditis, and even experiencing strokes due to the microvascular, microthrombotic changes that this virus causes. Cutaneous manifestations, right from the miscellaneous inflammatory syndrome, which is like the Kawasaki disease in children that is also seen in adults, to having COVID toes, having gangrene in the extremities, to having urticaria, angioedema, having vesicular bullous lesions. There have been many, many other things that have been seen that I shall briefly mention. And as I have mentioned earlier, the receptors for the SARS-CoV-2 virus are present all over the body, and really no organ system is spared from this disease. Now, when we look at the WHO case definition for a suspect case, we are looking at acute onset of fever and cough. The odds ratio is more than 3, or there are more than 3 of the following, sorry: fever, cough, general weakness or fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, and altered mental status. I would like to make a point on this altered mental status, because I personally have seen several cases where people I have known to be very well balanced and very stable suddenly developing acute anxiety, panic anxiety, and sometimes panic anxiety with depressive type of symptoms in a very short span of time, where on testing they were found to be COVID positive. And certainly we know that encephalitis and encephalopathy are both also known with this disease. So altered mental status is also something that should make us get a red flag and aware if it is in someone whom we don't expect to have the problem. And one of the following: within 14 days of symptom onset, residing or working in an area with high risk of transmission. We certainly are in such a zone ourselves. Residing or traveling to an area with community transmission, people are going to work, they are traveling, all that is happening. Working in a healthcare setting, that is clearly a risk factor for each one of us, and why we have to take care of all these things. A patient with severe acute respiratory illness and acute respiratory infection with history of fever or measured fever more than 38 and a cough with onset within the last 20 days requires hospitalization according to this WHO case definition. And a probable case definition would again be acute onset of fever and cough, or 3 of the above that I mentioned, or a suspect case with chest imaging showing findings of COVID-19, recent onset of loss of taste and smell in the absence of any other identified cause, which means the person doesn't have allergic rhinitis, allergic rhinosinusitis, doesn't have nasal polyps, and they suddenly lose their taste and smell, very high suspicion for COVID-19. And then unexplained death in an adult with respiratory distress who has been in contact with a probable or confirmed case, epidemiologically linked to a cluster with at least 1 confirmed case. And in all of these situations, again, having a high level of suspicion, testing these patients quickly becomes very important. A few unusual presentations in one series from Italy: 20.5% patients develop skin manifestations like red rashes, widespread urticaria, 1 case of chickenpox-like vesicles. Itching was mild or absent. Skin manifestations did not correlate with the disease severity, and these skin manifestations were very similar to that seen during common viral infections. COVID-19 can also feature signs, as we know, of small blood vessel occlusion, and hence it can come with petechiae, bruises, transient livedoid eruptions, vascular occlusion, can be neurogenic, can be microthrombotic, and can be immune complex mediated also. Acute drug reactions also need to be monitored, because multi-drug therapy is very common in these cases, and that might be the reason why these problems occur. There's a case consult of a 37-year-old man who had stomach pain, vomiting, diarrhea, but absolutely no respiratory symptoms and was COVID positive. And while his abdominal CT scan was being done, they incidentally found that his chest CT was also abnormal and had significant bilateral lung involvement. A 69-year-old woman with a history of laparotomy and new onset intestinal subocclusion with adhesion, who was doing well after an exploratory lapse, suddenly went into respiratory failure, progressive bradycardia, died in 3 days, Aspiration pneumonia, embolism, MI were all ruled out. Turns out it was viral myocarditis and was later on found to be COVID positive. Another physician reporting elevated cardiac enzymes without coronary artery obstruction. This is a very interesting feature, and that's why doing the troponins and the CKMB and those kind can be important in some cases, who went into shock with an ejection 40% and markedly increased heart wall thickness but had absolutely no lung involvement, was also COVID positive. There have been cases of idiopathic thrombocytopenic changes without fever or hypoxia. From Italy, there have been tricky situations that doctors have reported where a patient has only, as I said, loss of taste and loss of smell. And this became almost 100% guarantee that the person is going to be COVID positive. What we do have to realize, and my colleague Dr. Kapil Rathi will cover, the COVID test doesn't always come positive, and there needs to be a high level of suspicion to sometimes repeat it or look at other ways of doing that evaluation. The clinical presentation can also vary by age and sex. And what happens in these situations is this study, which was an European observational study done between March and April, found that the mean duration of symptoms were anywhere from 11.5 to almost 17 days. What we do have to realize is we are much better now at it. The ENT complaints were more common in young patients. The fever, fatigue, loss of appetite, diarrhea were more common in elderly patients. The loss of smell, headache, nasal obstruction, throat pain, fatigue was more common in women. The cough and fever were more common in men. What we have to remember that fever can be absent in up to 20% patients who eventually turn out to be COVID-19 positive. So we have to realize that respiratory symptoms and fever may not always be present, and we have to keep our level of suspicion quite high in these COVID times. Among the 17 fatal COVID cases that were detailed in China during the first initial phase, numerically faster older patients had problems within 11.5 days versus 14 days amongst people of other ages. Just a brief mention, I know this will be covered later, but non-pharmacologic preventive interventions are so important in this disease, right from using the right concentration of alcohol for sanitizing, hand sanitizing, cleaning of surfaces with hydrogen peroxide, sodium hypochlorite, benzalkonium, chlorhexidine, digluconate are less effective, so tend to be avoided. So look at what you're using in your practices and also recommending to people. Quick identification, quick testing, we keep encouraging this to our patients. Don't wait taking your antibiotics and your fever medicines at home. Try to get help quickly. Quarantine those who are close contacts of the infected people, preferably separate from the infected individual if possible. We all know that. Washing, social distance, maintaining, wearing the cloth, and if we have, as physicians, surgical masks or N95 masks, practice respiratory etiquette, disinfect frequently, touch surfaces. We saw that metal, glass, and plastic holds on to this virus for a very long time. Avoid crowds, close contact settings, and poorly ventilated spaces. And I think the ventilation to our clinics and workspaces is so very important that we do have to look into it wherever possible or give ourselves the breaks that we need from time to time. When we look at the efficacy of preventing transmission, we realize that face masks can reduce the transmission very, very significantly, and the odds ratio of just using any kind of mask brings down the risk of infection to 0.15. And the more the layers, for example, to a cotton mask, the more the protection, and viral detection is quite high without a mask, whereas compared to those with a mask when these are cultured and studies have been done. We also realize that for personal protection, maintaining the physical distance, hand washing, PPE are so important, and those who especially are elderly individuals or taking care of elderly individuals or those with comorbidities have to take even greater precautions, so much so that the WHO recently went on to say that even indoor wearing of face masks may be required in certain settings, and certainly something that we have to consider even to guide our patients and our own family and friends. At the end of my part of the presentation, where I give you a rundown of the different ways that this virus presents itself, all I can say is don't panic, stay safe, stay informed, keep exercising, keep taking care of yourself. Remember that this too shall pass, and the best things as an immunologist that I can tell you, fresh air and sunlight, there was nothing better than that ever created. A healthy diet, a fresh healthy diet, exercise, a good night's sleep, yoga pranayam where possible, supplements when indicated, not randomly, a positive attitude and mindset, and lastly, meditation, which is so very powerful in keeping us all healthy. Our colleagues from the other branches of medicine also support us in what we do, and we do look that as a positive thing. And with that, I shall end my part of the presentation. We will have the other two presentations by Dr. Kapil Rathi and Dr. Prahlad Prabhudesai, after which we will be opening up the panel for questions. So please keep sending your questions in. And thank you very much. If anyone would like to connect with me on our Telegram group, on our YouTube channel, or contact me for any help related to allergy, asthma, immunology, or your COVID cases, please don't hesitate to do so. Thank you very much once again. And I shall turn over to Dr. Pandit once again.
Thank you, Dr. Siddesh. Thank you so much. Excellent. You have covered extensively the things which you made us aware, how the cardiac things and the gastrointestinal things can be presented with the COVID and without having cough cold symptoms also. Our next speaker is Dr. Kapil Rathi, who is going to speak on diagnosis, dilemma, and differential diagnosis in COVID. He is gold medalist from Nagpur as an undergraduate. He did MD Internal Medicines from Mumbai. He has expertise in critical care from critical centers, both from US and Australia. I would request Dr. Kapil Rathi to solve our issues of diagnosis and dilemma.
Yeah, just
Dr. Kapil Rathi, please. How are you there?
yeah,
Please.
Just a minute.
Is gold medalist from Nagpur as an undergraduate. He did MD Internal Medicines from Mumbai. Sir, unmute yourself, Dr. Kapil Rathi.
Yeah.
That's.
Just a minute.
Yeah. You can share your slides, sir.
Yeah, I'm just asking. Yeah, anyone from Hetero has got my slide? Manor? Manor?
Yes, sir.
Can you just load my slides?
Yeah. Sir, is it visible?
Yeah.
It is visible in Manor. That's fine.
Yeah. So everyone can see my slides now?
Yes, sir. Perfect.
Okay. So Manor, just when I say next, so kindly move forward.
Yes, sir.
Okay. So thank you once again, Team GPA, and thank you, Sitesh, for having me on this panel, and thanks for that wonderful opening talk where you have actually set the ball rolling. And probably what we are doing for last 9 months or so, we are trying to just summarize, and now we are trying to reach the pinnacle where we know how to treat, and we know what is the way for pandemic. So we will have just a brief on antivirals in COVID-19. Hit hard, hit early is the concept. That is how we actually treat, and that is what we are treating for at least last 9 months or so. Next slide, please. So my talk will be in this flow. What is the current scenario? What is positive and asymptomatic? What is the strategy of starting early favipiravir? I think that is one of the most important points what we have learned from last probably 5 months or so. And obviously important of treating family members, because we don't want to spread it too randomly. That is what is happening off late because of this, all these marriages and all this, some bit of relaxation in the social norms. We are seeing a lot of cases which are coming up again, and obviously some a few words on post-COVID complications who are recovered from COVID-19, and basically home quarantine and asymptomatic patient diagnostic tool, and a little bit on inflammatory mark like D-dimer, ferritin, IL-6, and CRP. We all know this. Next slide, please.
So you're going to speak on differential diagnosis also, sir.
Yeah.
Yeah.
So we all know, I think Sitesh has given you the brief where we stand. Probably we are just nearing maybe a 10 million mark. So we are just closing to 1 crore as a case in India per se, and probably 1.5 lakh is somewhat the mortality what we are as of now. So probably we are going to get it more and more. And as we all know, COVID has been actually divided into 3 categories: mild, moderate, severe. And obviously most of the cases, like 80 to 85% of cases, will get recovered probably on a simple treatment at home, or basically maybe some on admission. 10 to 15% will be in the hospital for monitoring and probably for some kind of injectables, and probably 5% will be in critical care. Out of that, 2 to 3% will be really sicker, or so called as very severe cases. Next slide, please. So next slide, please. So now these are the challenges in COVID-19 pandemic era, where there are a lot of numbers of positive cases. We have got limited in health infrastructure. We all know how struggled we in last 4 or 5 months. Probably the initial part of COVID, later we were much better. How we all are overburdened with, as a healthcare system. Probably nobody knows better than us how overburdened we are. And obviously the cost of COVID treatment, which was stupendous to start with, has come down substantially low, but still it is a very high cost for an average Indian. And obviously a lot of post-COVID-19 complications, which we are seeing, and probably which are going to see in coming years for a lot of patients. Next slide, please. So these are all challenges what we were expecting in this COVID pandemic. Next slide. So symptoms of COVID-19, I think everyone knows now. Now it's very simple, all upper and lower respiratory tract infection, and little bit of atypical symptom, what Sitesh has also told you. Typically anosmia, paragypsia, and diarrhea, vomiting. So GI symptoms, a bit of respiratory symptoms, and some kind of unusual symptoms can be there, which can be a diagnostic of a COVID-19. So in a given pandemic, in this current situation, whosoever comes to you with fever, cough, and cold, unless put otherwise, turns out to be COVID. So you have to rule out COVID rather than ruling in, probably because most of us will be seeing the COVID patient, whether it is symptomatic or asymptomatic. Next slide, please. So classification of COVID according to Ministry of Health Welfare, symptoms are mild, moderate, severe. What we have discussed, I think it has been already been harped upon. How it is very simple to understand. But yes, I think the differentiation point from mild, moderate, or severe is going to be the respiratory symptoms and basically the presentation. So any person who has got a tachypnea, tachycardia, and hypoxia probably will go into category of moderate and severe. So any saturations which are less than 94%, and breathlessness or a tachypnea or a respiratory rate of more than 24 will turn out to be a moderate case, vis-a-vis any person whose saturations at room air without oxygen will be less than 90% and respiratory rate more than 30, it turned out to be severe. And obviously your radiologist is going to define you, or going to categorize your patient to moderate and severe depending on the CT scoring, what we do often in our patient. So I think radiology along with the clinical picture will make the patient into mild, moderate, and severe category. Next slide, please. So I think this is one of the most important slide for all general practitioner and probably for all the consultant also, because the season is on. Now we are in the middle of the winter, probably December, January, February. So we are going to see a lot of flu cases, probably H1N1 also, and SARI also. So now you are going to get a mixed bag of a lot of things. So now you need to differentiate between ILI or an influenza like illness, H1N1, and severe acute respiratory infection and COVID-19. So I think these are going to be interlap, but these are going to be basically interchangeable some of the time. But now you have to be keep your antenna up basically to differentiate, because you don't want to overtreat sometimes COVID, which happens in most of the cases. Because being in the winter, we are going to see a lot of these cases. I think first 4 or 5 symptoms are very common with all the illnesses, like fever, myalgia, cough, lack of energy, sore throat. I think breathlessness is something which will separate out COVID-19 from probably H1N1 SARI will also have breathlessness, but it all depends on the what kind of stage the patient present. But yes, anosmia and paragnosia is something which is very typical to COVID. I think if someone comes with loss of taste and loss of smell, probably you are dealing with COVID. Otherwise, most of the symptoms will be more or less similar. It all depends on the little history, probably some kind of workup diagnosis, and then you have to create your own diagnosis, and you have to rule out COVID rather than ruling in, because most of the patient will be presenting with a COVID-19. Next slide, please. So what is the gold standard? So how do you go about COVID-19? Once you suspect this patient is to be a probable or so-called suspected COVID-19, you need to confirm it either by serology or either by some molecular test, or probably another way is to do a radiology. So RT-PCR or reverse transcription polymerase chain reaction is being the most sensitive or so-called the gold standard for diagnosis of COVID-19. We all know this. This is how we do it basically, but it can be done for a lot of viruses, not only for SARS-CoV-2 but also for HIV, influenza, and so many viruses. But yes, RT-PCR is one of the tests what we have been relying upon. The only caveat with RT-PCR is that the sensitivity is to the tune of 70 to 72%. That means out of 10%, out of 10 patients what you are going to do RT-PCR, probably you will miss 3 patients in a given case. So that means your sensitivity is little bit on lower side as compared to the other things. So we want something which is more sensitive, more than 90% sensitive, but still it is the gold standard, still 70% sensitivity. And probably if you suspect that you have got a very high index of suspicion for COVID-19, if your RT-PCR is negative on day 1, probably you will repeat another sample after day another 48 hours, and probably you will get a good sample and probably get a good positive test. So if you do a repeat RT-PCR, your yield become more high and probably you will pick up more cases. But yes, RT-PCR still remains the gold standard. Next slide, please. Now, radiology, there are something to tell about. I think X-ray and CT scan both are with us, and probably we are gone away with X-ray. Probably nowadays X-ray has gone taken a back seat as compared to HRCT, because we all know the CT is more sensitive and more specific for COVID-19. A lot of atypical features which are there in CT are pathognomonic of COVID-19. We can just look at CT and we can diagnose it without having RT-PCR most of the time. But yes, on X-ray also you can see a peripheral damage to the lung. You can see in this slide, there are the arrows which are put up there. You can see this peripheral shadow which are there. Probably this will take a little more time as compared to CT to appear in that particular X-ray. So CT will pick up your disease much earlier as compared to and chest X-ray. And if your X-ray is showing this, probably already there are already 7-8 days have been passed in the disease. That is what we can infer. But yes, X-ray is also a good tool, but probably CT is more sensitive and specific tool for COVID-19. Next slide, please. Obviously, what I've talked about is CT, and there are a lot of features which are there. So typical ground glass opacity, typical peripheral nature of the disease, typical ground glass, and basically this crazy paving appearance, and probably sometimes the mosaic pattern, and sometimes this peripheral, the patchy consolidation which you can see. This is very, very typical of COVID-19. And there are a lot of scoring systems. There are CORAD systems according to which you can actually designate the probability of COVID. And then there are severity index where they take all the 5 lobes of both the lungs and they give some scoring. Depending on that, each lobe has got a 5 scoring of 5, so that makes 25. So out of that, how much lung is involved, according to that you get a scoring. So any score which is less than 8 is supposed to be mild. Any score which is supposed to be more than 8 and less than 16 is supposed to be moderate, and any score which is more than 16 is supposed to be a very high or a very severe. So that is how you can differentiate on basis of CT also how your patient is placed. It can actually give you a lot of idea how this patient is going to behave in coming days, probably which patient will require admission, which patient can be kept at home, and probably you can also dwell on the prognosis of this patient. Basically, you can also sometime in this patient, the patient who got more CT score index, probably this patient will require long-term ICU or long-term oxygen, or maybe some other, the injectables and everything. And basically, this patient might have more COVID complication, post-discharge. So this is how you can actually make at CT. So CT has got a lot of not diagnostic, but also the prognostic value also. Next slide, please. So these are our Brahmastra basically for diagnosing COVID-19. You could see, I think pulse oximeter is something which is mandatory for all of us. Everyone has got now pulse oximeter, not only at clinic but also at home. chest X-ray and CT scan, that is what I have discussed you. PCR test, that is what I have discussed you, and something about CBC. I think simple blood biochemistry can also give you a lot of information about what is happening to the patient, or what is going to be the diagnostic criteria for this patient. CBC is a simple test, but can give you a lot of information. So all these NLR ratios and other things have been talked about, and we all know about this. So more the NLR better, or what we can say is not. So more the confirmative is about COVID-19, and the moment your lymphocyte ratios comes up, or moment your lymphocyte picked up subsequently in another 7, 8, 10 days, probably you know that your patient is coming out of that inflammation and is going to get recovered. So your CBC and other biochemistry has got a lot of information about COVID-19, not only diagnosis, but also again for the prognosis. Next slide, please. So these are the most important investigation that what we can do. I have talked about CBC, I talked about NLR ratios, then I talked about, other things, biochemistry, but most important being D-dimer. I think D-dimer is something where we all looked upon at baseline, probably after 5 days, and probably once it is higher, then we check it very frequently, because it also gives you idea about how is the immunity behaving, how is the internal milieu, how pro-thrombotic the patient is, how about immunothrombosis which is happening in this patient, and probably that will also decide about the prophylactic and therapeutic anticoagulation. That is the most important cornerstone in the therapy of COVID-19. CRP, as we all know, it's very non-specific marker, but yes, it goes up. It doesn't goes in thousands, but it goes in hundreds. So probably any CRP which is more than 50 plus or 70, 80 plus, mostly give you hint about underlying COVID-19. Ferritin is again an acute phase reactant. It can go in any acute injury, but so is also in COVID. So it goes very high in COVID. Sometimes it goes beyond 1,000 also. But yes, ferritin is another good marker to actually navigate your treatment and actually prognosticate whether this patient is in cytokine storm, or whether it's recovering or something like that. IL-6 is something which is now being a little bit of dicey, but yes, again, it's a marker of cytokine storm or hyperinflammation syndrome, what we call as CRS, cytokine release syndrome. So any IL-6 which is more than probably 40, 50 can be considered as very high, and can be gone for maybe an anti-IL-6 kind of a therapy. But of late, we are not relying too much on IL-6, because we know there are a lot of caveat in IL-6. But yes, another way to look at that, it is also a good marker to actually prognosticate or to anticipate the cytokine storm which is impending. And LDH again is again a non-specific marker. So again, it can go high in any lung injury for that matter. So does it happen in COVID-19. So we have got this armamentarium of CBC, D-dimer, CRP, ferritin, IL-6, and LDH, which we can do serially. A single value has got no value. You have to do it on a serial basis, and you have to look the trend of the trade, so that actually you can anticipate and you can intervene as soon as possible the moment you see that trend is not against or trend is against the patient. So that is how you look into all this test basically. But I think simple CBC and this basic test give you a lot of information about what is happening inside the body of that COVID-19 patient. Next slide, please. So complications of COVID-19, I think we can discuss in length later also, but I think these are why we are all worried about COVID-19 is that, COVID-19 doesn't kill, but, the complications of COVID-19 that are very, very, catastrophic. And basically it is not the live virus which causes the problem. It is the dead virus DNA which causes this cytokine storm, and probably cause this pneumonia, ARDS, sepsis, septic shock, cardiac failure, renal failure, stroke, and pulmonary embolism, deep venous thrombosis. So there are a lot of things which happens in a COVID-19 patient, and we all have seen and probably will see more in coming days, all these complications of COVID-19. So that is why it is important to understand not only COVID-19 as a disease, but also the effect or the post effect after COVID-19. Next slide, please. So after having all this information about COVID-19, about the diagnosis, the interpretation, the differential diagnosis, and probably the therapeutic armamentarium comes around, and the most important being the role of an antiviral, which is favipiravir. I think I'm not saying this is a game changer drug, but I think it has helped us a lot. I think probably after favipiravir and remdesivir, we have seen that mortality has gone down, and probably we as a physician, we as a COVID specialist have been, more at ease and at a more relaxed, because we have got something to offer to this patient. So let's talk about favipiravir. Next slide, please. So what is favipiravir? Favipiravir is basically a broad spectrum antiviral which was developed from Toyota Chemical or Fujifilm Group from Japan. This is not a new drug. This has been approved, or this has been there for last 3-4 years. It has been approved in Japan for influenza. Now it has been repurposed as an anti-COVID-19 drug. And basically what does it does? It is basically, it selectively inhibits the RNA polymerase. So what it does, it inhibits RDRP or RNA dependent RNA polymerase, which is the important enzyme for the multiplication of the virus. So therefore it will halt the multiplication and the progress of the virus, the transmission. So that is the whole idea of giving an antiviral like favipiravir. So is the remdesivir. The both does the same job. The thing is that favipiravir is an oral and remdesivir is an injectable form. Now the favipiravir has shown activity against influenza virus, not only influenza virus, but whole lot of virus like yellow fever virus, foot and mouth disease virus, flavivirus, arena virus, guinea virus, and COVID-19. So it's a broad spectrum. Just like we have got a broad spectrum antibiotics, we have got a broad spectrum antiviral. So you can use for a lot of viruses favipiravir, and so is COVID-19, because ultimately it's a coronavirus. Now the favipiravir has been approved for experimental use. It is an emergency use authorization which has been given to favipiravir for COVID-19, not only in India, but also in Italy, China, and Russia. So there are a lot of countries which are using favipiravir as an upfront drug in the treatment of COVID-19. Next slide, please. So this is in simple in cartoon what we have depicted, that there is a favipiravir which is a prodrug. It goes into your body, get converted into the active form which is called as favipiravir RTP, which inhibits the replication of SARS-CoV-2 by inhibiting RDRP enzyme. That is the most important action of favipiravir. So to make it simple, it is a RNA dependent RNA polymerase enzyme inhibitor which will halt the replication of COVID-19 virus. Next slide, please. So what are the salient feature of favipiravir? It's a broad spectrum. I've told you it should be initiated within 72 hours. To be very precise, I think we should initiate it within 24 hours as soon as we make a diagnosis of COVID-19. I think that is as soon as possible is the mantra. The moment the hit early, hit hard. So moment you diagnose, you start it depending on the condition of the patient. So early initiation will help to overcome disease progression. What it does, it offers faster viral clearance within 4 days. So that is the most important thing. So if you have a patient who's a COVID-19, if you don't give favipiravir, probably it will take 8 or 9 days for your body to eliminate that virus. But if you give favipiravir in this patient, probably within 4 days, your virus will be cleared, or you will be non-infective within that 4 days, and your symptoms will also improve. So what you are doing, you are making your patient non-infective as soon as possible or as early as possible, so that he doesn't become infected, or he doesn't become a source to spread the disease. And also what you are doing, you are preventing the complications. So you are preventing that person from going from mild disease to moderate disease or probable severe disease. Therefore, you are not limiting only COVID-19, but probably you also limiting this post-COVID complications. So that is very important. That is the role of favipiravir in COVID-19. So it is as early as possible, preferably within 24 to 48 hours of diagnosis. So that is how we give it. Next slide, please. So these are a lot of clinical trials. Next slide. So we can see, and this is the latest study what was published in Times of India in Mumbai only 21st of November. So they have checked in 150 patients, and what they have seen, that it is a very safe drug. So most important thing is very safe drug. It is very effective drug in viral clearance, and obviously it decreases the COVID-19 complication. So it is not only decreases the viral clearance or increases the viral clearance, but also decreases complication. So that is the most important part. Next slide, please. So this was the study, and the dose we all know. I think dose are something which we all know by now very well. First day it is 3600 milligrams, followed by 1600 milligram from day 2 to day 7, and you can give maximum up to 14 days. But probably 7 to 10 days is something where we have given maximum to our patient is up to 10 days. Probably very in few cases we have gone up to 14 days. So that is very important. Next slide, please. So it seemed to have a faster clinical cure and importantly faster viral clearance. That is very important. So 70% of the patient in the favipiravir arm achieved a clinical remission or a clinical so-called good endpoint at day 4. So probably in 96 hours, you are going to get virus out of the body in 70% of the patient if you give favipiravir as soon as possible. So that is what this study did. And this is a trial. This is yet to publish in a proper peer-reviewed journal. But probably this is the trend what we also seeing in our clinical practice. Next slide, please. So hit hard, hit early. I think this mantra is going from so many years in critical care. We all do we give antibiotic as soon as possible, so that at least we can have that first punch as soon as possible on the viruses or bacteria. So same is for in COVID-19. You have to hit hard, you probably hit very early in the disease. Next slide, please. So doses of favipiravir, I think that's a no-brainer. And nowadays, because of this, all especially to hetero and other companies also who have bring 800 milligram tablet, I think the pill burden has gone down. So doses are very simple. If you got an 800 milligram tablet, you have on day one you have to give 2 tablets of 800 milligram plus a tablet of 200 milligram. That makes 1800 milligram in the morning, same in the evening. And from day second onward, it will be 1 tablet twice a day of 800 milligram from day 2 to day 7 or day 2 to day 10, depending on the severity of the patient. Next slide, please. So a little bit of just to know something about favipiravir, where it should not be given. Probably it should not be given in pregnancy, in lactating women, in patient who have got history of gout, in children patient less than 12 years of age, patient who have got creatine clearance of less than 30, and probably a patient whose OTPT on a liver profile is more than 5 times of normal. So these are some 4 or 5 situations where you have to restrict yourself from using favipiravir. Otherwise, it can be used in most of the patient very easily. Next slide, please. So drug interaction, just a few words. I think pyrazinamide, ripaglinamide, theophylline, famciclovir, the best part is that it is only for 7 days. So you can stop all this drug for 7 days, give favipiravir, get out of favipiravir, and then you can again restart all this drug. So if patient are on all this drug, you can stop favipiravir, you can stop this drug and give favipiravir. Otherwise, just wait for 5-7 days before your COVID is over, and then you can stop all these drugs. So that is very simple to understand. So it's a drug which is very easily manageable with all the side effect profile. Probably because of this 800 milligram tablet, now the pill burden has gone down. So probably now patients are more comfortable in taking favipiravir on a regular basis. Next slide, please. So what are the benefit of starting antiviral early? I think I've harped upon that. I think it has got a faster viral clearance, faster negativity from swab positivity, probably limits the complication, probably limits the patient from going from mild to severe disease, and probably will make patient feel much better, or will feel give confidence in the patient to come out of this COVID as soon as possible. Next slide, please. So treatment of family member, I think currently in home quarantine, we all know this as a general practitioner, we must have been treating all these patients. So I think there has been a lot of, I think, over treatment for a lot of people, with all this antioxidant, vitamin C and all other stuff. I think Sitesh has given the right message. You can't use in all the patients, give in a selected patients, but yes, you have to observe these patients who are at home quarantine very closely, just to monitor, just to see that they remain in the mild category, they don't progress to moderate category, where probably you might require some hospital admission. And obviously, all these asymptomatic patients have, if they have got some kind of symptoms or their age is little on higher side, plus some comorbidity, probably we should start favipiravir in this kind of patient. Next slide, please. So post COVID-19 complication, just a word about this. We have seen and heard and been treated a lot of patients with post COVID-19 pulmonary fibrosis, cardiovascular complication like myocarditis, myocardial infarction, diabetes because of steroid overuse, high blood pressure, deep vein thrombosis, pulmonary embolism, blurred vision. There are some reports of central, retinal artery occlusion and all stuff like that. So there have been a lot of complications which are there, but I think the most important complication what we have seen in our practice is basically a long fatigue or a prolonged fatigue syndrome. I think fatigue is something where your patients have been sick and have been tired of getting up and everything. So they're just lost, or they're just drained out, and this probably lasts for 2 to 3 weeks post COVID. So that is something which we are seeing in our day-to-day practice. Next slide, please. So I think diagnostic stage, these are my last couple of slides, post COVID-19 recovery. Next slide, please. So maybe a single breath count, which can give you a lot of information about your lung, the lung hygiene or lung health. Peak flow meter, I think that is very easy to understand, because spirometry you can't do in this COVID-19 pandemic, or you have to do with very utmost care. CBC, I have told you, it is very good for not for diagnosis but also for prognosis. D-dimer depends on that, at time of discharge, what was your D-dimer, which actually will warrant you how much amount of thromboprophylaxis or anticoagulant what you need to start and how long you need to give, depend on the D-dimer level. Cardiac evaluation, very important. All these patients, we have seen at least 2-3 patients I have seen personally who have developed myocardial infarction, stroke and pulmonary embolism post COVID-19, 15 days after the recovery. So one need to understand, one need to keep a very close watch on this kind of patient. And obviously we'll check the sugars properly, because this patient, either they will be a pre-diabetic or a non-diabetic, or probably turn out to be diabetic after long steroid use. So that is very important. So ideally we should evaluate this patient actually fortnightly, every 15 days, for this kind of complications, and probably manage all these biochemical parameter and metabolic parameter very well before actually we give them as a go that you are actually COVID free. Because actually 4 weeks post COVID are very important as far as complications and monitoring are concerned. Next slide, please. So I think that was my last slide, and that is where I end. So I have given you just an overview about how to diagnose, how to differentiate, what kind of treatment typically with favipiravir, and a glimpse of what is a post-COVID-19 complication. So I thank you very much for the patient listening. I will be there to answer any of your questions. So back to
Thank you. Thank you, Dr. Kapil Rathi. You made it very interesting one with the flavipiravir has to be used by family physician at the earliest, and you developed a confidence for them. Thank you so much. We will have question answer later on. Our third speaker is Dr. Prahlad Prabhu Desai. He is going to speak on outpatient management and follow-up plans. He is one of the leading chest physician metropoles of Mumbai. He is attached to Lilavati Hospital Research Center, Guru Nanak Hospital Research Center. He has more than 42 publications in national, international journals and respiratory medicine books. He is a member of European Respiratory Society. He is D&B teacher at Lilavati Hospital. He's having his own Pratibha Prabhakar Pulmonary Rehabilitation Center at Goregaon. Sir, please, we are very keen to listen to you, as we are family physician, and how we can manage at outpatient level COVID-19. Thank you, Dr. Prabhu Desai. Yeah. Dr. Prabhu Desai, please.
Yeah.
Thank you, sir.
At the onset, I'm thankful to organizers and General Practitioner Association, Electropharma, Sitesh, and Sitesh, Rathi, and me have up till now given almost 3 programs. This is the 3rd program. Okay. And I'm thankful to all of you. Dr. Sitesh and Dr. Rathi has given you an entire complete idea about the diagnosis, presentations, and the management of COVID, all the drugs which are being explained. So my job is very simple. Now let's see how our family physicians can manage COVID at home. And this has been now because of the BMC has allowed to keep the patient in the home. And earlier, almost every patient were either isolated in COVID care center or COVID hospitals, and we were not having any chance to manage the patient at home. Now, what is better? Whether it's a COVID patient to be managed at home is better, or whether it's COVID managing in the hospital is better. It is very important, interesting to know that most of the time, because of the panic, the patient gets to come to the hospital and gets admitted on the day one when the COVID test is done or when symptoms starts. And for the first week, at least, there are hardly any, complications patient develops. So obviously, patient is sitting like that in the hospital, and he gets tired, bored. It's very difficult for him to remain in the hospital for such a long period of time and with very minimal things going on. Afterwards, the real complication starts from the 8th day to 14th day, or even sometime later on. And when patient is discharged, he generally have the problems at home, and then he rushes back to the hospital. And this is a common thing which you run. As a physician, chest physician, when you are managing this patient, many times we get calls when the patient is discharged and developing complications and then re-getting admitted. So what is very important is that home management is extremely important. If you manage the patient home till he develops problem, and you anticipate that this patient is going to get problem, and at the time of complication, if you admit the patient's hospital stay decreases, he gets a correct treatment also that time, and obviously his expenses cost can be reduced to great extent. What is very important to understand is that timing is very important. And this is an extremely important draft. You should know that the incubation period is around 5 days. Symptoms are again for next 5 to 7, 8 days, and then the inflammatory complication of the patient, which starts from the day 10 to day 15 and may extend. Now, remember one thing, that typical syndrome which patient develops is if the viral load is say minimal. If the viral load is very huge, then the disease become fatal and everything is prolonged. Even virus remains in the body also for prolonged period of time. And when patient is having a severe disease, again in between the typical and severe, so obviously this viral load decides the patient's symptomatology and also the inflammatory phase of the patient. Okay, more the viral load, more the particle size, more the particles of the viruses, more will be the prolonged inflammation. So what is very important is the timing is very important to curtail the viral load. Okay, and that is whose hand? This is the family physician's hand, because here the patient is with the family physician. Okay, and so if you treat the patient correctly with the antivirals in the beginning, avoid steroids during this phase and give only antivirals. Okay, your viral shedding can come down significantly, viral multiplication will be reduced, and obviously the less virus particles, lesser will be the inflammatory response. And here is the right time to give anti-inflammatory drug. So you can give right antivirals during this time. You can avoid unnecessary medicines like steroids during early phase when patient is in the patient has no complications of the viral disease. And then here at this time where you can use purely steroids and there is no role of antiviral over here. So timing is very important to understand the symptomatology, also the complication, management, and even investigations. Yeah, early stage, if you do the COVID RT-PCR, will chances of getting positivity is very high. Later on, it becomes less. So what everything is in the family physician's hand to correctly diagnose, correctly treat in the early stage, anticipate the problem where patient can get complication, and then transfer to the hospital for a necessary treatment. And current policies of the BMC, which are correct policy, so that this patient can be home isolated and managed well. Now, today in my talk, we are going to discuss how we can manage the patient at home so that burden on the patient can be reduced, burden on the hospital can be reduced, and family physicians will get interest in managing this COVID. And it's a very clear cut method. It's like a mathematical, basically the methodology of treating COVID-19. See the viral load, how it's there and how it reduces afterwards, and later on it's all particles. Okay, actually speaking, this is the first 5 to 7 days you have the problem. Even after 8 days, patient is non-infectious. That is also very important. You should know, because there are no viruses. There are all virus particles after almost 1 week. And after 10 days, he is 100% non-infectious. Okay, so there are no chance of that patient going to give infection. And here is the immune response, inflammatory response, complication. So see, up to 28 days, you can get complications. So that is very important. So later on, understanding the inflammation can remain for a prolonged period of time, can develop complication, may require a prolonged steroid therapy. This is also a family physician should understand, and that is a crux of management of COVID is generally in the home, at the beginning, at home, in between, in the hospital plus minus, and later on definitely at home. And you are all aware that 85% of the patients are in the mild phase. Okay, we are lucky to have the medicines freely available and we are using those in correct time. So probably viral shedding is reduced, virus maybe become, this is my thoughts, virus maybe become weaker. So if you see in the family member, only one person is moderately sick, remaining all very mildly sick. Probably the right time the antivirals are being used, especially favipiravir, leading to a lesser amount of complication in the patient and lesser amount of severity in the patient. That is possible. Okay, So regular use, this is not used in Europe and America. So that's why they have got a much higher mortality rate, much higher spread compared to our country. See, in Mumbai, despite of lockdown being open, now after Ganpati, everything is in open slowly. Incidence of COVID pneumonia is calmed down significantly. Or 30% beds are empty actually, if you ask me. Okay, ICUs are empty 30%, despite of being opening up. Okay, there is something great to observe. The severity, as Dr. Rathi has gone on, is much lesser. We have very less patients on mechanical ventilator today, and because of the probably our management is become more wiser, or maybe because of the availability of medicine to us very freely. As you rightly said, these are the mild to moderate disease which already been discussed symptom. I don't want to say, but one has to know that clinically stable may become deteriorate eventually, and this needs to be observed. Okay, now what patients should be our treatment destination depend at home, whether we are going to manage depends upon the risk factor. Okay, remember risk factors are a persistent fever. That is also a risk factor. If your fever in the COVID fever generally goes away in 3-4 days, it's mild. Okay, but suppose fever remains after 5 days or 7 days, and if the fever intensity increases 101, 102, that is not a good sign. Okay, these patients are either having sepsis or maybe leading to a cytokine storm. Persistent cough, which is there, later on after 1 week, is also you have to observe. Breathlessness, that patient feels suffocation. Hypoxia. Now, hypoxia to occur means less than 90% saturation is too late. So, how we detect early hypoxia? Make the patient walk in the house regularly, morning, afternoon, night. Measure his pulse and saturation. If post-walking saturation, say around 6 to 7 minutes you walk, or even more than that, if saturation remain above 95, 96, it means what? It means he had lesser amount of shunt inside, so he doesn't have hypoxia, and he doesn't have any likely to develop any complication. Even if the patient has got fever up and down, he is safe to be kept in the hospital. So you can detect hypoxia early by doing this. And day-to-day clinical presentation is important over there. The manifestation of headache, chest pain, or all those things, or pain in the legs should not be neglected. Or if he has got disproportionate breathlessness, suddenly he becomes more breathless, and heart rate increases significantly, but saturation may be remaining normal. These also patient needs to be observed. And these are the blood parameters. Now, all the blood tests have been discussed. I will give importance to only 2 important blood tests. CBC, in the early stages, the lymphopenia needs to be observed. Lymphopenia is a good marker of severity of disease. Lymphopenia is a good marker of improvement in the patient. And very severe, sometimes zero lymphocyte count also can happen. Remember, that is a very severe COVID pneumonia. And this is something which has to be observed. So I give a lot of importance of CBC in the indoor admitted patient to understand when my patient is improving or not. Same thing, you can do it on OPD basis. CRP is another good important. Remember, it's a non-specific marker, but in COVID-19, this is generally very less. It's not very high. It never go above 70. Okay, if it is very high, hundreds, 200, like that, 300, it means this is not pure COVID. There is some complications happening, and this complication could be infection. See, a lot of our patients are diabetic, so they may have a silent infection like urinary infection, cystitis, pyelonephritis, cholecystitis, sinusitis, sudden abdominal infection, maybe an abscess somewhere developing. So these are the things also can happen because of the in our diabetic patient, and one needs to be CRP is a very good indicator, okay, of this thing. SGOT, AGPT is always elevated in mild infection. It's generally not very high, never more than 100, 150. But this is important test to be done, because if you want to give favipiravir to the patient, you have to observe. Yes, we are not denying favipiravir exams are a little elevated because they have become viral infection. So even favipiravir causes decrease in the SGOT, AGPT when you do follow. But that is, we should know that how much SGOT, AGPT is there. Similarly, creatinine is absolute contraindication if the very high creatinine level. But borderline creatinine level is high, we monitor the creatinine and give favipiravir. Okay. D-dimer is an important test, but remember D-dimer cannot just justify that higher D-dimer means you have to give lowered every patient with COVID who is admitted in the hospital, we give LMW. But yes, you can also give either oral anticoagulants if the risk factors are high in patient like cardiac or patient has got diabetes and other vascular diseases like stroke in the past and elderly person, then you must give an adult anticoagulant because everything of pathology of COVID is perivascular, remember, or vascular capillary level. Okay, so you may have no DVT and no thromboembolism, but there may be clotting in the peripheral capillaries. So you have to understand as a family physician, and you must give these anticoagulant or even aspirin-like drug can be given. It is important to rule out dengue and malaria. Okay, by family physician when you are treating with the PUO of short duration and influenza like symptoms, or may not be having the cold and cough, you may have just fever, and you should not miss dengue because platelet counts and other malaria may have, you must ask for malaria antigen or look for classical manifestation of malaria. So RT-PCR ruling it out in acute fever febrile illness is very important. So if you RT-PCR is done in a febrile illness and it is negative, instead of doing a scan, I would give importance to finding out other causes of fever. Okay, maybe urinary tract infection, maybe malaria, maybe, so all those things, dengue fever, and the thing one should have bacterial pneumonia, which also can happen, remember, but generally their counts are very high. Procalcitonin is a good biomarker for differentiating viral from a bacterial infection. Okay, higher the procalcitonin, rising procalcitonin, very high levels of procalcitonin indicates bacterial infection. COVID generally we have got a normal, we are below normal, 0.01, cutoff is 0.5. We see many times 0.5, 0.005, like that in COVID-19. So this is something which is one should know, and you can use those biomarkers. Okay, when you manage at home, okay, mild to moderate COVID, but the COVID infection who doesn't have hypoxia, I will consider we should manage at home. No risk factor, we should manage at home. Then you must know that there is a space is available or not to manage, because other patients should not, other people should not get infected. There should be a separate bathroom and a room for the patient. If possible, then these patients can be managed very well at this thing. And there should be a proper self distancing should be kept. Patients should not come out. A patient should wear a mask inside. All the relatives in the house should mask inside. The floor should be clean. The whatever the utensils we use should be clean, or that patient himself should clean it. Okay. And but it is very tricky sometimes. Elderly persons are there, 80-year-old, 85, mother and father. Somebody needs, you have to, so don't get, we should tell the patient not to get worried about that. You wear N95 mask, you wear a face shield, okay, wear a gloves and go and help the your parents or your close relative. By there is no need to use a PP in the house. Remember, it's very important to understand key hands and the air. That is the only thing which provides pedal. If you wear the clothes, you can straight away change the clothes once you enter into the. You can feed them. Okay, feeding is very important over there to the elderly people. That is what real problem is. You wear this and come out and change your clothes and put it in the soap water, hot water. You can clean them later on. So no fear should be there to manage the patient. An interesting thing is what patient is infectious before he gets the disease. It is very important to remember. After symptoms are over, these patients are non-infectious. That is very important. CDC says after 10 days, but there are studies show that even after 7-8 days, they become non-infectious. And if you are using antiviral at home, they become non-infectious in 4th or 5th day. Okay. So avoiding the aerosol generation, that is using nebulization, is very important. Speaking loudly generates nebula. Singing in the house generates. So these are the things we should do. Self-monitoring is done, pulse saturation, etc. monitoring. The supervising healthcare and the nutrition is very important to them. They should eat well. They have diarrhea, so obviously you have to modify your diet. Okay, and their regular medication they should take properly. So don't avoid their antihypertensive, anti-diabetic, and other medications. If they are taking, they should see that they get a proper medicine. And care of a family members around should be considered. So this is how they need some home gadgets. Remember, a thermometer, a pulse oximeter, diary to write down. Okay, it is very important. Even when they are consulting you, you should tell them to write down all your reports: hemoglobin, WBC, lymphocyte, CRP on a diary. and take a picture and send you on WhatsApp rather than sending all patients reports to you and then you are going to compare it with the previous report. Very difficult to do it on WhatsApp. It makes a lot of headache to actually consultant and physician to see all previous report and compare with the same time. Patient can do it very well on his own, all those things, if you explain to them. So this is how you can put it. These are the risk factors where you have to be careful when you keep the patient at home. Uncontrolled diabetes. Remember, if you want to give steroid, it further becomes uncontrolled. Per se, COVID diabetes become uncontrolled. Sickle cell disease, chronic kidney disease, immunocompromised patient, cancer patient, COPD, ILD patient, patient with the ejection fraction borderline, okay, or heart coronary disease patient. We should not actually manage this patient at home, okay. And again, these are the alarming important thing as I discussed: fever, breathlessness, drop in saturation, higher D dimer, rising D dimer, worsening lymphopenia, rising CRP. These are all very important. This needs patients to be hospital and do not delay hospitalization. That's very important. Don't keep extra day. One day early only you admit if you find. And all these drugs which have already been discussed in COVID management, you can use that. And don't want to go into these drugs again. You have already been covered very well. And there are literature showing good trials coming up in that. Even anti-inflammatory drugs like steroids, you should use it at the time of after the inflammation phase starts. Okay. So if it is, remember, it is not only for hypoxia. Remember, it's not only for hypoxia, because hypoxia will take time. But if a patient after 8-10 days fever rises, it remains high, you can use it along with antibiotics, corticosteroid, but use proper dosages of corticosteroids. Remember, I prefer prednisolone 1 milligram per kilogram body weight, and it's always variable dose you can use as per the patient, because requirement of steroid depend upon the patient's body weight and individual. You can't give a fixed dose of 6 milligram dexamethasone to all patients. It may not work. Okay, so it has to be modified as per the requirement, and one can use it. We can use antibiotic with the help of understanding the underlying disease, whether the bacterial infection there or not. And you can use steroid for 5 to 6 days, proper high dose, proper steroid, and then you will get really response well at home. But all those patients with risk factor, better to admit and then give the steroid. Otherwise, most of the young patients you can manage this way. Risk infection to keep in mind. You can step up sometimes steroid, but don't use 5 milligram BD prednisolone, 6 milligram dexacortisone from beginning. It is not correct. Okay, so steroid is the second part of the COVID-19 infection. Now, I already told you about importance of D dimer, rising D dimer. Is very important, or even you can use drug like aspirin. There are reports showing that even viral replication is reduced because of the early use of ecosprin and other drug. Okay, so we use thromboprophylaxis either in the form of Clexin, especially pregnant ladies there who has there is no medicine for her. The only medicine for the pregnant lady in the house is hydration, and second important thing is that keep a low molecular weight heparin to the. Okay, because both the pregnancy and COVID is a prothrombotic, so you can use it and then observe the patient properly with pulse saturation, etc. All that, and whenever required, then only you can hospitalize the patient. Otherwise, no, you can't do CT scan, X-ray on this patient, but you have to monitor clinically. Remember, vitamin C, vitamin D, zinc. A lot of role is there in the immunity of the patient or immune modification, improving the innate immunity of the patient. But in a COVID-19, there is no proofs on that. Okay, we use it. Okay, there are role of higher vitamin C in preventing cytokine storm, but hardly any data on that. If you talk about data, they are more of a placebo, but you use it. Okay, sometimes patients themselves ask, we give some vitamin to us, we are feeling fatigue, tired, etc. So anyway, these drugs have got limited role to play, and you must know about that. Okay, the hospital care and home care, we have understood the difference. We know the markers of the disease progression, like worsening thrombocytopenia, troponin levels remaining high, prolonged prothrombin time, liver enzyme rising, okay, elevating D dimer. Generally, we do not give importance to IL-6, and you should never ask on OPD basis IL-6 level. These are the markers which you do in the hospital. Why IL-6 is not? Because even IL-6 is normal. Patient can have cytokine storm, and we give sometimes the drug. Even IL-6 takes time. If you collect the blood, and if you send the sample late, okay, your IL-6 level we have falsely high. So this can happen, and it is very unreliable as well as the testing. But it is a marker and we use it. Very high level of IL-6 gives complications. For example, a patient is hospitalized and we found that we had done IL-6 level 3000 IL-6, which is we never see in COVID-19 so much. These are things seen in sepsis. So in fact, sepsis also is a very important, bacterial infection also important cause of rising IL-6 level. Remember, it's not only COVID-19. So these are the tests which we give importance with limited value. Okay, so we should not ask routinely, and don't do it follow up also with the IL-6. Elevated level of procalcitonin has some importance. Now, the recovery of COVID is concerned, it all depends upon whether your infection is mild, moderate, or severe. If mild infection, recovery can happen in 8-10 days. Okay, 2 weeks, there is recovery is almost complete in mild, moderate. But in severe, it may take 3 weeks, sometimes 4 weeks, even sometimes 6 weeks to recovery to happen. It all depends upon the initial load of viruses. Okay. And the complications of the COVID-19 depend upon the whether the patient has got where is getting managed, ICU versus high dependency unit, and whether he requires oxygen at home, or whether he requires underlying vascular diseases or obesity, which never very important to know that obesity is a very important marker of complications that patient can develop, and very difficult to manage COVID pneumonia in obese patient. They are very difficult, remember. So this is something which you must know, that all these fatigue, cough, and etc., headache, body ache, all these, okay, they are lingering symptom reported, okay, on the telephonic surveys, and they remain much longer than after the patient recovers from the symptoms. So a patient gets all right in 14 days, but his cough can remain for a month. His breathlessness can remain for 1 month. Okay, his oxygen level can come back to normal if there's a disease inside. Then fatigability, depression, anxiety, sleep, which is large number of patients has got a sleep disturbances, and remember, confusion, etc., cognitive dysfunction can happen. And this is also a American European study showing that, UK study shows that it is not only for ICU patient. Remember, it also can happen to the patient who are managed at home as well as in the ward. In this study, the ward, okay, like post-traumatic stress disorder is very common. Fatigability, highest level of fatigability is there, and breathlessness feeling. So this is something which can happen to not only to serious patient, but mild, moderate patient also. So this is something which you should know, including their memory get affected, and their confidence goes down, etc. Now their voice becomes affected, intermittent headache can come, and even low grade type of fever they get with chilly sensation can remain for a longer period of time. And long-term health problems can remain in these patients, which mental health, musculoskeletal, brain, lung, and heart disease can remain in these patients for a prolonged period of time. The most important complication which as a chest physician we are worried about is fibrosis, venous thromboembolism, extreme fatigability, insomnia, headache. Family physicians are going to get a lot of frequent calls on that, and patients needs to be tackled, and we'll see how we can do that. Now, these respiratory complications aims to follow is very important. First of all, whatever doctor writes on the discharge is not written by a doctor, remember, is written by somebody third party who is not seeing the patient at all, remember, because he is not in COVID area. So there is a lot of gap between what is written by the doctor upstairs and what is written by discharge. And so patients many times get a false or wrong medicines, remember, this is my observation. And then either doses are incorrect or something that left behind, diabetic medicines are not written. So discharge card should be seen by a doctor who's treating at least once on telephone, or family physician should go through a discharge card and see what is the lacking in the discharge card. He can easily identify if something is not missing or not correct. So that is one. Then respiratory complications should be observed, fibrosis, and this can be done by doing a scan at the time of discharge. One can know what is the status of the lung, okay, if it is not done earlier. Then acute patient needs, what are the things like oxygen therapy, etc. Then adherence to the advice given the patient should follow. And there are sometimes post-COVID tests are required, like CBC, D-dimer. We do sometime on follow-up, okay. I have seen a patient dying at home, okay, despite of being managed very well in the hospital because of the sudden cardiac arrest, vascular complication, even by embolism. So these patients need sometimes the follow-up important investigations. Like, for example, high-resolution CT scan in a moderately severe COVID patient who's discharged from the hospital. At the time of discharge, if it is not done, then at least after 3 weeks of the his patient become better, you should do this lung scan. Why it is important to do lung scan? Because you can come to know the fibrosis component, traction bronchiectasis, subpleural scarring, honeycomb happening, okay, or there may be consolidation remaining. That's called organizing pneumonia. Then this patient will get benefit of steroid. You can give steroids little prolonged period of time. Okay, antifibrotics, yes, their role, but we are sometimes overreacting to with the antifibrotic drugs and giving every patient antifibrotic. Every patient doesn't require antifibrotics. Sometimes patient may require a prolonged steroid if there is a ground glassing more, if there is a honeycombing, if there is a consolidation is there. Antifibrotic is required for the patient who has got a traction bronchiectasis or fibrosis inside subpleural or septal thickening is there. And if there is a honeycombing doesn't happen so fast. But yes, severe COVID pneumonia gives early honeycombing also. We have seen that some picture. Pulmonary vasculopathies also can be happening. Lung function test is a very important test. Post-COVID, after 1 month, patient is safe. There is no virus. So no PFT technicians or you're going to spread disease, remember. So PFT we do come. In fact, they are most safe patient to do complete pulmonary function test, 6 minutes walk test in our PFT lab because they are non-infectious now. Okay, as well as COVID is concerned after 1 month. Okay, so we do that and we found that if there's a diffusion defect in them, there's a drop in saturation 6 minutes walk test, or there is a patient has got a restrictive disease, this patient needs a special care. Now, this is a patient, the scan of in 1.5 months, see, you can see the traction bronchiectasis, how it is there. Okay, you can see this. This is something what we call as a traction bronchiectasis, bronchiolectasis, and this patient will require antifibrotic. There is a fibrosis which is developing. Okay, so this is how. But this is all consolidation, ground glassing, etc. Okay, so this year patient will be more benefited with corticosteroid and he has come back to over here. So now he will require more of antifibrotic. Pulmonary rehabilitation is a evidence-based proven therapy for post-COVID sequelae, not only for the COVID fibrosis, but post-COVID what is that called as a post-traumatic stress disorder in the patient, cognitive dysfunction, and patient with insomnia, fatigability. This patient will go with proper 6 weeks pulmonary rehab program. They will get significant benefit because all these are web-based program and meditation, yoga, pranayam is included in that. Pranayam as yoga and meditation has great role to play in treating this post-COVID patient because they have got a lot of psychological disturbances, and with the proper therapy for them, they come out of that. Okay, so this is something which is very important. There are evidence today. I'm not going in the depth of. Prior or by doing 6 minutes walk test and finding out desaturation happening. Second is that importance of home isolation facility has to be there. Medicines has to be properly given. Steroids and low molecular heparin can be given in the safely in the OPD basis in the home. And rehabilitation is an important component of post-COVID care. I think with this, I would like to stop my lecture, and I'm thankful again for the organizers.
Thank you, sir. Thank you so much. Sir, I would like to know before some questions I get through chat. Sir, this pulmonary fibrosis remains permanent or it recovers completely? And second thing, does pulse oximetry readings changes after the pulmonary fibrosis? Does it comes to normal after some time, after a few months? Or it remains below 95, below 92?
Yeah, the fibrosis is the end stage of that inflammation process. Okay, once anything gets fibrosed, okay, the chances of fibrosis coming back, at least there is no medicine proven up till now. Okay, what is very important is that if you stop the process of fibrosis, okay, it will be really that can be done with the medication. And steroid has got a very less role to play over here. Remember, antifibrotic drugs have got a better role to play. Remember, all these antifibrotics are used in idiopathic pulmonary fibrosis, which is a pathophysiologically a different this thing. It is a recurrently happening progressive disease. Okay, the constantly pathophysiology is happening in the patient over the period of time, and then antifibrotic is used to reduce the process. COVID-19 is not like that. Okay, remember, it's a one-time injury to the patient, and then this inflammation going into a scarring. Is any infection finally goes into scar, and if the severity is there, a severe infection is there, obviously there will be more scar. It will not be progressive. But remember one thing, I have seen a progressive fibrosis happening in this patient, in few patients. Why this happens? Genetically, these patients may be prone to develop a progressive fibrosis, and viral infection have precipitated it, the chain reaction happening to the patient. That is possible. If patient has got underlying some mild lung fibrosis like hypersensitive pneumonia or collagen vascular disorder, it can again progress the patient's fibrosis, and this can happen. But generally, what I have observed that in so many patients I have seen, a large number of patients, the lung is inflamed. Okay, it is not fibrous, and you see the recovery happening. You see the scan which I showed you.
Yes.
The lot of inflammation lesion is there which can regress back to it, and fibrosis which is there underlying, which can progress to very few in patient. Remaining normal lung can take over the function. Okay, we have yet to see the follow-up PFTs in all patients, but then we'll come to know whether the FVC is improving or not, diffusion improves or not. That is too early, I feel it is now.
Okay.
But yes, not everybody goes into a progressive fibrosis. Very less amount of patient goes into progressive fibrosis.
So oxygen saturation comes back to normal, sir. Oxygen saturation over a period of time.
Yeah, that is what is the interesting thing. IPF patient will never have improvement in oxygen saturation. While these patients in the beginning they have got hypoxia, but later on their hypoxia gets controlled. Even walking, they don't get desaturation. Extensively damaged lung I'm talking about, and there is a good improvement in the as well as oxygen levels are concerned after walking. The dyspnea sensation is there. But remember, the fibrosis is there, but that may not all part of the lung is not going to go into fibrosis in many patients. That whatever the injury has happened to that part of the lung, that part of the area, the fibrosis can happen, but other lung can take over the function. That's why that is what I observed is that the hypoxia remains not it improves in later on.
So one question by Dr. Ajay. Quite a large number of these go into dialysis after COVID infection. Role of low dose injection DEXA is provided good during hospital and home treatment COVID infections. Injection DEXA for these patients who go into for dialysis and mild CKD. It's question to Dr. Rati. Is it true that mild CKD patients, quite a large number of these go into dialysis?
It all depends on what kind of injury you have got. As you all know, it's a systemic disease. So anyone who's a pre-existing say stage 1, stage 2 CKD can progress. As we all know, ACE2 receptors are very predominantly at glomeruli, and probably that is where you can hit that. But yes, not all patients of CKD will go into dialysis. Not all patients will go into CKD, but probably, and as far as your question on dexamethasone, there is no role of DEXA other than once your patient is admitted. Once your patient is out, when it is at home, probably only given condition of maybe fibrosis, or whether you feel that there is a lot of inflammation at the time of discharge also, probably you will give extended steroid for maybe 2 to 3 weeks. Otherwise, there is no role of any steroid post-COVID discharge unless excepting 2 or 3 situations.
Thank you, sir. Dr. Hitesh has asked how to select amongst anticoagulants during hospitalization, low molecular weight heparin and rivaroxaban. Dr. Kapil, would you like to answer this?
So it all depends, it all depends on operator choice. But yes, the way forward is to use NOACs or novel oral anticoagulants. That is what we use. So it all depends on, the primary level of D-dimer and obviously the comorbidity. So any patient who is to start with, who is a prothrombotic, now at the time of discharge, if the D-dimers are more than 2 times normal, so probably if it is more than 1000, then probably we will give all these patients, and NOACs or an anticoagulant for at least 45 days or so-called 6 weeks. Now the choice can be between any of the 3. You can have dabigatran, you can have apixaban, or you can have rivaroxaban. Personally, what I use is basically apixaban because it has got, it can be used for a lot of other conditions. Plus, you can't have to monitor the dose for renal failure also. So it is very safe and it has got the least amount of tendency to bleed. So that is why my personal choice is apixaban. Otherwise, you can use either of the three, but it all depends on the level of the D dimer, the prothrombotic conditions, and the comorbidity.
Yeah, Janak, any questions you got on the?
Yeah.
Yeah.
Dr. Sucheta Kataria has asked, in pregnant woman, if D dimer is normal, would they still need low molecular weight heparin?
Yeah, right. We use at the hospital if patient is admitted low molecular weight heparin. At home, well, it all depends upon but what level of pregnancy patient is. Probably in the third trimester, I will definitely use it. Okay, LMW at home, and patient can take LMW at home. This thing, because I'm if patient has got a hypoxia, to 100% I will give low molecular. Hypoxia in the sense lower saturation. Obese patient, pregnancy, definitely will consider.
Now, can we give Febiflu to lactating mother?
No.
No. Okay. Then the other question is, can we give ivermectin to lactating mother?
No.
Any other question, Janak? There is nothing in the chat box
Yeah,
here.
1 second. I will just go through it.
Yeah,
Can
please.
remdesivir and favipiravir be given when serum creatinine is raised? I think you have answered.
Please answer.
We take consent of the patient and we consider for remdesivir in the patient. Even the creatinine is 2, 3, that range. Okay, creatinine clearance we see and see. If the benefit is going to be more to the patient, then we consider. And we have not, in fact, sometimes we have seen that creatinine comes down. Okay, if you treat with the antiviral. But yes, hydration is very important over here. Remember that you require a significant amount of much more higher fluid, 100 ml per hour. Sometimes fluid is to be given to the patient who has got a creatinine high and who is in COVID-19. And we always take a nephrology opinion, remember, and our nephrologists we are using remdesivir even if the creatinine is higher. Okay, but rising creatinine on remdesivir, okay, we will stop the remdesivir definitely.
Okay. How long doses? How long does the patient need to take allopurinol for uric acid post favipiravir in case of uric acid high level is high?
Actually, there is a asymptomatic hyperuricemia. Remember, so this patient have hardly any symptoms, so you don't get worried about it. Okay, I don't think we should treat that. I don't know what Dr. Rati and Dr. Sitesh says.
Yeah. I think hyperuricemia is a transient phase which happens with favipiravir. So it will come down the moment you stop. So you keep on changing every third and fifth day once on favipiravir, and probably within a week's time, the uric acid will come down once you stop favipiravir.
Now, one question is like this: there is a great controversy about favipiravir. It's only a placebo, no action on COVID. That is, can you put some light on?
I don't think so. See, the thing is that there are two things, evidence-based, evidence not available, evidence is there, and there is no evidence. Okay, there is definitely that there may not be sufficiently large evidence about favipiravir. Okay, but whatever the evidence today is there, it is definitely proves that it is better drug to give in the safer and better drug to be used in the viral infection. There is no controversy on that, and I think my own experience, Dr. Rati's experience, and Dr. Sitesh's experience, they will talk their own experience. And my experience that I'm very happy with this drug. In fact, sometimes I feel that remdesivir is inferior as well as favipiravir is concerned, because the reason I'll tell you why. Okay, because favipiravir we start 3 days advance before in the right time. That's why the favipiravir is an advantage over remdesivir. Remdesivir is given when patient is admitted. We generally don't. No patient gets admitted on day one of fever. They get admitted when they are 3-4 days fever is there and that was gone. So we missed the bus actually, because 5 days virus survives for 7 days. After giving remdesivir after 8 days for dead virus is useless. Okay, so practically speaking, antiviral the biggest advantage of favipiravir is that it can be started on day one or probably before somebody else develops in the family member and they have symptoms. Before you do the COVID, you can start them. That's what I don't know what Dr. Sitesh and they feel.
So what is the role of ivermectin? Is there any role of ivermectin in the COVID treatment or no role?
A difficult question you are asking. Ivermectin we use, I use it, okay, and very difficult to prove whether it's useful or not useful. But at least there is a theoretical evidence is there. There are no studies will come now because there are people going on, studies are going on. But as a drug, it has got a role to play. In even there are states they use as a prophylactic medicine. Even doctors take when they travel with the medicine. I mean, you ask me, there is no evidence. It's very difficult to prove unless you do a proper study in ivermectin. Okay. What, Sitesh, do you use it, ivermectin?
Unmute yourself.
Both as a therapeutic as well as prophylactic. I want two answers for ivermectin.
What was the second thing, Dr. Bhatt?
Prophylactic.
So I am
0, 7, and 30, and then every month.
Yeah, I am not convinced about hydroxychloroquine, and I'm not convinced about ivermectin.
Okay.
As an immunologist, I have known these drugs for different reasons and for different uses, including autoimmunity, including infections. I believe that whatever little anecdotal data is there suggests that if ivermectin has to be used, it needs to be used with doxycycline by itself. It may not have much benefit, but really the data is not that strong. Now, someone may say that the data is not strong for favipiravir also, but when you look at the data very carefully, favipiravir has definitely more data than ivermectin has right now. And for hydroxychloroquine, the data from across the globe has been negative. The only positive study has been in India, and that's a retrospective analysis. It's not a prospective double-blind placebo-controlled trial the way we would like it to be done. So my take is, while I do believe very strongly that placebos work, and placebos work in up to 40% people in very powerful trials with very powerful drugs, I personally believe that this is something that is still up in the air. If you believe in it and you take it, there is a good chance it may work for you. If you don't believe in it and you take it, you may end up with side effects. So at this point of time, the jury is up there. I would love to hear what Dr. Athi has to say. We've heard Dr. Prabhudev said. Athi, I'll put you on the stand. This is a tough one.
I know, if you believe science, then there are a lot of things which are unanswered, basically, but sometimes you have to just move out of that shell and to give something. So probably, yes, data wise, hydroxychloroquine is big no, we have been stopped, that is what is. Ivermectin is something which is 50-50, but to be very honest, I'll put my my hand on my heart and say, yes, I do use in my patients. We do use in the dose of 150 to 200 micrograms per kg. We give it for 5 days. We give it as, I'm not a big fan for prophylaxis, but then I'm a big fan for therapeutic. That is, and I combine basically. So my three go-to drugs are basically favipiravir, doxy, and ivermectin. That is what is I give to my patients who are on an OPD basis or who are a mild patient. So that is how I give it, but not more than 5 days, and in the dose of 150 to 200 micrograms per kg. But yes, data is coming up. The good part is that it's a very mild drug, so you don't get any side effect. That was not the case with hydroxychloroquine. You will have a lot of cardiac toxicity and other things, so you are worried about that. But this drug you can give very safely, and probably we are doing more justice to patient rather than harming them by giving ivermectin. But yes, if you put me in the witness box, and if you say whether data is there, there is no data. But yes, your gut feeling says that it works, and probably it is working in our patient.
Now, just on favipiravir, initially, don't want to name with due respect, the very eminent pulmonologist was strongly against favipiravir. Very strongly. I mean, I know I've heard him so many times, and I know. I mean, it's purely individual. I'm not trying to. I know. Still, everything is. So, any take on that?
No, I think I'll just take with this, and maybe Dr. Prabhu sir and Sitesh will also have their opinion. But I think, initially there was a lot of hitch from a lot of people to use favipiravir. But over a period of time, since last 4 or 5 months, they have themselves gathered that confidence of writing favipiravir and seeing the result. And I told you, initially there was a lot of hitch from patient also. The tablets were too much and everything. Nowadays it has gone down to very few tablets. And as rightly pointed by Dr. Prabhu Desai sir, I think it has to be as early as possible. So if you use within 24 hours, probably you won't, or you will not be requiring using remdesivir in this patient. So that is what takes favipiravir little ahead of remdesivir. For remdesivir, you need to have patient to get admitted, plus other lot of other stuff are there. Probably favipiravir is something where all general practitioners and physician like us can treat 80% of your patient at home. So, Prabhu sir?
Yeah, I agree with you.
One,
And no
sorry,
question.
yeah. Now with
Sir,
favipiravir with doxy is good or favipiravir with azithromycin?
Uh-huh.
That is a question.
Prabhu sir will take this.
Well, I think there's hardly, I can't really answer. Azithromycin has got, really speaking, no role over here as an antiviral. Doxy is, there are people where it again has got a, purely doxy has got no role, but ivermectin doxy has combination maybe role. But if you don't want to give ivermectin doxy is okay, but you must use favipiravir. That much I can tell you. Okay.
Janak, but sir, thank you so much. I will still
Thank you,
proceed
sir.
with this the three
Yeah.
speakers, but they have developed confidence in us. Dr. Prabhu Desai, Dr. Rathi, and Roy, and use of Flavivir, because we are 8 months old into this. What we might have heard 6 months before is not there now, and we must appreciate Prabhu Desai and Dr. Rathi. Yeah, it may develop confidence for
But I
us.
think even I
That
don't
was
know whether even ICMR data was
it is,
also.
sir.
I mean, I'm trying to
Rathi sir,
recollect.
Prabhu Desai sir, Satish Rai, you develop confidence in us. Even after
Exactly,
8 months of COVID, we are going through so many CMEs. But today you have given a really eye opener, and I hope those who are attending this particular web meeting will definitely have confidence to start with. What do you say, Janak?
Yes, definitely. The moment you see a COVID positive patient, I think one should start
Yeah,
with favipiravir
absolutely.
at least for 7 days. What
Yeah,
I think.
absolutely.
No,
This
no,
year
excellent. I mean, all three of you are
is
far excellent. I am very happy.
absolutely. Yeah. Anything else, Janak? Any other
No,
questions?
no other questions, sir.
Sincere thanks to
Thank,
the General Practitioners Association. A very, very big
Thank you.
thank you to Dr. Vaja. Dr. Pragji Vaja was instrumental in inviting me
I
to
know.
he is here now. He has come.
really
Yeah.
appreciate Dr. Prabhu Desai and Dr. Rathi. They do a fantastic job every time I've been on a panel with them. So thanks to you all, and thanks to Dr. Pandit and to the entire team, Dr. Janak, Dr. Bhatt. Thank you very much. I think
Thank
there are still some questions, but the questions will keep going on.
Yeah.
So I really appreciate all of you all and your time, and to all my general practitioners who are out there,
Yeah.
a big thank you for taking time and spending some time connecting with us and learning something that we have to give from our experience.
Thank you,
Thank
sir.
you.
I will
you.
request our Honorary Secretary, Dr. Vazi Praja. Dr. Vaza, please
Yes, sir.
give
Yes,
a
sir.
vote of thanks. He is for a lot of us, we know him. He's a COVID warrior. He is into front line into the city of Mumbai. He was in Latur for blood relief, what not, blood donation drive, what not he is doing.
He
I'm
can
telling
share
you
his
that
own data, basically.
absolutely, he's got his own data, and we are very proud of him. He's
And
doing a fantastic job. Vaza,
and
please.
the most
Before he begins, for all of you three speakers, I am talking off the book. It's a little bit unparliamentary, but I call him a blood sucker. I mean, he had collected 1,000 bottles of blood during Ganpati festival at Lal Bagh Cha Raja. 100
Oh,
bottles
beautiful.
per day.
No, no, it was. No, it was. Anyhow, thank you, everybody. Thanks, Dr. Bharat Bhatt.
He is a
Dr.
recipient of Governor's Award as a
Yeah,
I mean,
Yeah.
absolutely. Thanks for sharing. That's right.
Thank you, everyone, for your kind words. Sir, today's Dr. Sitesh, sir.
yes.
Sir, this was a fantastic program, and to be very frank, you are the instrumental for today's program. And especially you all three esteemed distinguished speakers. Like we can label it as a trio, Brahma, Vishnu, and Mahesh, for to fight against the COVID, this disease. I think you all three have delivered your insight of the subject in a very simple, conducive, and a very what Dr. Pandit sir and Bhatt sir also said. Okay, you have not only taught us, but you have equally boosted our confidence to deal with the COVID patient. Suppose if you had heard your talk some few months back, I think the percentage of patient going to hospital would have been lessened from our corner at least. Am I right, Dr. Bharat Bhatt?
Yes,
Yeah,
I think
yeah,
you
yeah,
have put it very
absolutely.
nicely.
Yeah,
Yeah,
But then
absolutely.
Dr. Prabhu Desai will swear at us. His ICU rates are going down. He's already complaining
Yeah.
indirectly.
no, God is for everybody,
No, I'm
and
just
Prabhu Desai is himself is a God. So
Yeah.
there is no, it is not a question, but it was a overall a fantastic talk. And once again, I thank all three distinguished speakers. And sir, Siddesh Roy, sir, I'm little selfish. We would like to have a similar or a related to your immunology, such kind of
Yes.
webinar in future also. So this on this platform, I'm requesting you to keep such programs in future. May not be immediately, but after a few months, and I'm sure you will never deny it because you are a great teacher, you are an all-time teacher, and you are patient for teaching. And yes, equally all three speakers, especially Dr. Rati, Dr. Prabhu Desai, we are really impressed, and I think all the listeners, all the audience, they also agree with me. And equally on this occasion, how can we forget the hetero people for their educational grants, especially Shailesh Shakolkar and his team. So on behalf of General Practitioner Association, Shailesh bhai, we salute you for your cooperation, your help, and your association with our General Practitioner Association. On this, equally, I thank all the participants, all the audience, all the delegates who made their afternoon, I think, memorable one. After listening all three speakers,
Compromising their sleep. Yeah.
ah, so once again, I thank Dr. Sitesh
I
sir,
don't think so. They have
from the
compromised
bottom
the
of
sleep.
heart, Dr. Prabhu
It
Desai
They
was
have
sir,
work.
and
learned
Dr.
something.
Rakesh.
They've got lot of confidence.
Huh?
Yeah,
They've,
yeah.
Now
they
that
have
is
done
what
something. They have got lot of confidence to use
Yeah,
Favipiravir
yeah,
like anything.
yeah.
Yeah.
it was
Absolutely.
work.
They
It was work.
have made the
Absolutely.
treatment very easy.
Yeah.
So
Yeah, yeah.
once again, on behalf of General Practitioner Association, and on this occasion, I also thank our President, Dr. Bharat Bhatt sir, and our moderator, Dr. Pandit sir, and of course, how can we forget the Janak sir? He is the host, he is our, IT department, this, information technology department. And he becomes the host and he arranges all this program. So once again, thanks to all our speakers, thanks to all the, audience, and thanks to hetero people. Special thanks to Sailesh Bhai. Thank you all.
Thank you.
Thank you.
Thank you,
Thank
sir.
you very much.
Thank you, sir. So nice.
Thank you. Bye bye.